Julie Evans. I'm going to be chairing the forum for today. I'm the current Melbourne Children's Global Health Fellow. And I'd like to start this forum by acknowledging the traditional owners of the land on which we currently stand, the Wurundjeri people of the Kulin Nation. I recognise the Wurundjeri people's cultural, spiritual, physical and emotional connection with their land. And I honour and pay my respects to their elders past, present and emerging. And I also extend my respects and welcome to all First Nations people who might be joining us from around the world. So a couple of quick announcements before we get started today. One announcement is the Melbourne Children's Campus Student Symposium. I'll pop a slide up for this at the end, but for those of you on campus who are students, whether Masters or PhD, please submit your abstracts so you can practice presenting in a friendly forum. And the second announcement is that I will be finishing my role as Global Health Fellow at the end of this month, so I want to thank everyone for their support and encouragement with the work that I've been doing. So thank you. So without further ado, it's my pleasure to introduce three wonderful speakers for today. I'll start off with Associate Professor Amy Gray, who most of the audience will already know, who has more than 10 years of experience in global child health focused in Southeast Asia, particularly Laos PDR and Vietnam. Amy is a consultant paediatrician and Director of Medical Education and the Education Hub at RCH and Associate Professor in the University of Melbourne Department of Paediatrics. Her fields of expertise include quality of care for children and newborns in health facilities, medical education and education capacity strengthening in both high and low resource settings, and on a personal level has been a mentor for many paediatric trainees with an interest in global child health, including myself. We also have with us Dr. Pauline Wake joining us online from Port Moresby in PNG. Welcome, Pauline. Dr. Wake is an anaesthetist, a lecturer and head of the discipline of anaesthesia and intensive care at the School of Medicine and Health Sciences, University of Papua New Guinea. Her interest is in paediatric anaesthesia and has done fellowships in India and here in Australia. With this experience, she's focused on improving medical education for anaesthetic trainees in PNG, including the incorporation of the virtual platform to reach trainees outside of Port Moresby. And last but certainly by no means the least, Dr. Eugene Kua is an advanced paediatric trainee who has a strong interest in clinical education and peer mentorship, and Eugene will be our main presenter for today as I understand it. Eugene was the 2021 Laos Clinical Education Fellow and has been involved in the introduction of child mortality reviews in major paediatric centres in Laos and the development of online-based resources for medical students and doctors. So thank you in advance to all three speakers today. If you could please save your questions to the end for those in the room, and for those of you online, at any point throughout the talk, please post your questions on the Q&A or the chat, and we'll come to them at the end in the panel discussion. Thank you so much. Over to you, Amy.
Thank you, Nat, and thanks for thanks for all your work actually with the Global Health Forum and your time as the Global Health Fellow. I was going to mainly set the scene, and it's strange standing here in Melbourne with surging case numbers and massive issues with workforce and skills issues and capacity issues, and I feel like I don't need to set the scene for why we want to talk about education and workforce issues related to COVID. We began this conversation actually back in 2020. So this paper that you can see in front of us was our initial exploration of what our junior doctors were experiencing in Melbourne midway through the first year of the pandemic. And it's there online if people wanted to access it. But really it spoke to a loss or a disruption of professional identity with separation from their teams and relative heavy restrictions at the time, meaning they didn't have the normal contact with interprofessional members of that team. It spoke to a loss of the consultant by the side as someone to look for modelling and guidance and development of that professional identity. At the time, there were actually very few patients in hospital, and for more than anything, it spoke to a void in terms of the clinical content that was available both for experience and learning. And at the time, we were worried about what those implications would be 2 years later, and I think it's interesting to reflect on them 2 years later, where we have paediatric trainees who have only ever trained in paediatrics during a pandemic. But at the time we were doing this work, we did start to wonder if we are experiencing these difficulties, what are people in our region and in countries with access to less resources than us, and what are they experiencing and what are those difficulties, so that we can maybe think about what might be needed in the future in terms of help and support. And so Eugene was kindly doing a lot of remote work for Lau at that time and stepped into the bridge to take on this research, and I'll hand over to him to explain what we did and what we found.
Thanks, Amy. So I'm just looking that way. Right. I'll be presenting our research study results. It was titled A Qualitative Study on the Impact of COVID-19 on Continued Medical Education in Low to Middle Income Countries. I'm just going to be using a couple of abbreviations. So LMICs is going to be referring to low to middle income countries, and HICs will be high income countries. And I think I do use CME, which is continued medical education. All right. So in terms of our outline of the talk today, I'm going to start off with a little bit of background just to give a bit of context, and then I'll talk about what we did for the study. I'll talk about a little bit about the results, and then where to from here in the context of those results. Then we'll have a chat to Pauline and get a bit of a Papua New Guinea perspective on how they dealt with changes of delivering medical education during COVID. Right. So COVID became a known NTD to us in, I think, December 2019. In August 2020, there was a policy brief by the UN General Secretary who commented that we were facing a potential generational catastrophe in the context of the impacts that were felt on education worldwide. At that point in time, I think 1.6 billion learners were affected or impacted across 198 countries worldwide. And the closure of schools and other learning centres of education had impacted around about 94% of the student population. And then when we look at low to middle income countries, that number rose to around about 99%. So this is some statistics from a survey that was done in early 2020 by the International Association of Universities that sent out an initial survey to around about 400 universities over 109 countries, looking at what the initial impacts of COVID-19 were on higher education centres. And as you can see, fairly early on, there were already some major disruptions, mainly looking at the green and the purple. 30% had mentioned that our institutions were partially open, but there were still major disruptions, and up to 59% had all their campus activities stopped and institutions closed. So it was quite a significant impact relatively early on in the sort of pandemic days. So I guess, why do we care? So I guess we all are aware that there's sort of a relationship between medical education and delivery of healthcare services. We as healthcare professionals, we go through many years of education, and even do ongoing education as professionals, with the hope that that we will be able to deliver a standard of care out and serving our communities. There is an assumption that improved medical education will lead to improved medical healthcare outcomes. However, in actual fact, the evidence for this is a little bit less robust out there in literature. And I think this is a fair sort of assumption to be made in the setting of LMICs. Things that we take for granted in HICs, for example, access to expertise, new teaching pedagogies, which we take for granted, which we use on a day-to-day basis, if kind of implemented in LMIC settings, may have significant impacts to improve healthcare outcomes. So we know that there is a gap in healthcare, a gap in health between HICs and LMICs. These are some sort of statistics that everyone should be relatively familiar with. Non-communicable diseases here, maternal deaths, as well as child mortality. And so you can see here that the low to middle income countries are relatively overrepresented with these statistics. The gap also extends to capacity, and what I mean by capacity is in terms of expertise and research. And so this was a paper done in 2016 that looked into all papers surrounding maternal health interventions that came out of LMIC countries between 2000 and 2021. and they wanted to look at how many of these papers were actually led by home authors or authors that came from LMICs, and that number was only around about 60%, so there's potentially you can interpret that as a gap in skills. So our concerns were that given the effects of COVID and what they may have on sort of detrimental effects on continued medical education, that these gaps in health might be widened. And I guess CME in LMICs have a number of reasons. There are limited resources, so these include human and financial resources, and just considering in terms of the economic sort of impact that COVID has had worldwide, the financial is one of those big ones there. There's a relatively limited infrastructure and potentially a lack of particular specific expertise. And also, there are stretched healthcare systems in which medical education is embedded in. This is another set of statistics also from that survey done by the International Association of Universities, and just to highlight the sort of discrepancy of impact that can be felt between HICs and LMICs. So I'm just going to reference Africa and Europe here. Europe, I'm just going to make an assumption that these are all HICs, and we know that Africa has a high level or weight of LMICs. So in terms of classroom teaching replaced by distant learning, you can see that Africa was only able to do that at that point in time, 29% of institutions versus 85% in Europe. And then when you're looking at the overall amount of teaching that was completely cancelled, there's quite a discrepancy there, 24% in Africa and 3% in Europe. So again, impact can be interpreted as being felt potentially larger in LMICs. So given all that, we wanted to know what the state of medical education was in low to middle income countries, and we did this initial study around about, I think it was July to October, so 1.5 years down the track since the beginning of COVID. We wanted to develop an understanding of what medical education looked like in LMICs as they responded to COVID. And we wanted to do this by getting individual perspectives of educators on the ground and exploring how they dealt with delivering medical education in the context of challenges and opportunities presented by COVID. And so we did this through semi-structured interviews. And why we wanted to do this was essentially to identify common themes, challenges and opportunities to providing a base for relevant action and achievable action into the future. So we did that analysis through thematic analysis to get common themes that were common over variable contexts. So this is a little bit of a table that just is a brief summary about the educators that we interviewed. So we interviewed 10 educators that came from 8 countries, LMIC countries, as defined by the World Bank. We had a largely more of a representation from the Asia-Pacific region, with one educator coming from Africa as well. 10 educators might seem like a small amount of educators, but we're still able to get thematic sort of saturation with that theme. And as I said before, our interviews occurred between July and October. I'd also like to point out that most of the educators came from medicine, so there's a relatively kind of higher skew towards the medical sort of viewpoint in terms of medical students and education. So now just moving on to results. So we were able to derive 5 major themes throughout our analysis. They include navigating change in altered and divided teaching spaces, and this sort of describes the sort of changes that medical education had to adapt to. And then 3 other themes of curricular impact, trusting the new workforce, and evolving education. These are sort of the subsequent consequences of those changes in the education landscape. The curricular impact was divided into 2 themes: crevices in clinical content and compensation in delivery and assessment, and evolving education on those 4 sub-themes: expertise, infrastructure, drawbacks, and affordances. So I'm going to talk about each of these themes, and I'm going to preface them with a quote from one of our educators that kind of sums up the feel for what that theme is talking about. And so we've just gone through that process again, changing into COVID wards, and now our numbers have started coming down, and so we're going back to normal. So it's like a cycle as far as numbers in clinical teaching is concerned. So this is speaking to the theme of navigating change, and The experiences that were experienced by educators in LMICs was relatively similar to that experienced by educators in HICs. Essentially, the medical education was at the will of COVID fluctuations. COVID fluctuations impacted on healthcare policy, whether or not this be travel bans, social distancing, lockdowns, as well as group gathering limitations. So those policies would subsequently filter down to hospitals and educational institutes, which subsequently affected the way that medical education students were able to experience education at that time. There were variances between LMICs, but we also noted variances within LMICs. So, for example, in some places in India, they had regions that had tiered approaches to COVID restrictions, where others didn't. And in places like Indonesia, where there are islands, lots of islands, you'd find some islands who had COVID had really strict lockdowns, where others who didn't have much COVID were able to continue on with their medical education as they saw fit. So there's quite a bit of variation in between them as well. So close your hostels, shut the institutions, send them home. They can attend online classes from home. So this is speaking to altered and divided teaching spaces. And again, this is sort of a similar experience in LMICs as well as in HICs. So what we kind of discovered was that there were altered university and hospital environments, and this was to do with around about access as well around spaces. So in hospital environments, you'd have places where they could be converting whole wards to COVID wards, and in universities, they'd be blocking out smaller classrooms because of small sort of spaces where they couldn't large number of group of students. With regards to access, there was anything from complete shutdown to modified scheduling, where perhaps smaller groups of students would attend university campuses or hospitals at particular times of the day for particular durations of the time. There was an overall transition towards remote teaching, and so with this came sort of investment, or the need for investment in new infrastructure. The experience of educators in PNG was that because of this transition, they had to invest in screens to facilitate telehealth. So those are one of those major changes that occurred that provided alternate opportunities. Additionally, in terms of remote teaching, from the educator's perspective, they had to start performing education from places other than the university, so brought a lot of that stuff home. So there was going to be a question about whether or not they had the infrastructure at home to be able to facilitate education. Some universities were very proactive about this, sending out surveys initially early on to assess what the needs of educators were, and providing options, one of which were to provide them with equipment at home, which was great, so that could facilitate education, but also organising spaces within university campuses that were fully equipped with good internet and service like technology, screens, cameras, so that they could facilitate quality sort of medical education. And lastly, in this area is the effect on human resources, and this was essentially specifically centred around reduced time for clinical education, given the focus on service provision during times particularly of COVID spikes. And so educators who had both education and clinical roles found that a lot of their time that was siphoned to clinical duties where they would otherwise be using that time for education. Of course, there were also less opportunities for educators to teach in the setting of illness, as well as sort of fatigue and mental health strain as well. So the next theme I'm going to talk about is curricular impact, and as mentioned before, this has been divided into two sub-themes of premises in content, and compensations in delivery and assessment. So my students couldn't see severe malnutrition or TB with spondylitis. Actually, we still have a lot, but I don't know where these patients are. They disappeared. It seems like we only have one disease. So this is speaking to premises in content. And this is probably more related to the clinical curriculum, where educators really lamented the loss of clinical breadth. And this came in sort of multiple forms. For example, surgery, a lot of elective cases were cancelled, and I think this is the same experience here in HICs. And so they were only kind of exposed to emergency cases. Additionally, a lot of presentations to hospitals were COVID, and a lot of the non-COVID stuff ended up staying at home or not presented at hospital. In the general population, there was a stigmata associated with some hospitals, which meant that they wouldn't present to particular hospitals because of fear of catching COVID as well. Associated with students and learners not being able to attend clinical spaces was the loss of authentic learning environments and experience, which the educators were also quite concerned about, particularly for the latter years of medical students, like the final years, because these experiences or those years were seen as quite important for their transitions into professional work life. And then additionally, there were also missed opportunities from a professional development point of view, and this is more targeted towards postgraduate, junior work, postgraduate or junior professional workforce, where peripherally out in the peripheral that come down to metropolitan central centres to get clinical skills updates. But because of COVID, the inability to travel and perhaps for infrastructure, these things were cancelled, and so they didn't get their annual sort of updates in their skills. There were sort of slivers of light, and so particular specialties such as anaesthetics and ICU, who are at the forefront of treating COVID, did get increased opportunities for learning. And then there was also this talk about future pandemic preparedness, where experiencing pandemic medicine would prepare this generation for the potential of future pandemics if they were to occur, which is something that potentially was a challenge for the current generation of medical workforce who hadn't experienced pandemic medicine before. And then for the clinical years, we are still adapting. We couldn't figure out the best program for the clinical year students. So this is speaking to compensation, delivery and assessment, and I've kind of divided up into the theoretical curriculum and clinical education, clinical curriculum. And so from a theoretical perspective, most of this was fairly amenable to remote learning formats, and particularly where pre-existing infrastructure or practices of remote learning had already been occurring. So, for example, there was one educator in Indonesia who worked with sort of professionals who had to be flexible with their learning sort of timetables, and so for them they had the option of sort of asynchronous, synchronous learning, where they'd have recorded lectures plus the availability or the ability to attend a real life education. And so having had that in place, it was a very easy transition to move everything into that format. Another thing that was sort of pressed upon in the setting of this online environment was getting students to attend conferences, whether or not that be local or international, although the utility of that was up and down, limited by the fact that some of these conferences were sort of not contextually relevant, but also language barriers. People speaking English very fast and so not having enough time to process what's been said. From the clinical curriculum point of view, I guess the impact really depended on where in the the academic year this occurred in. So I can give an example. In Vietnam, their clinical year or their sort of academic year for medical students usually involves in the first half of the year they have theoretical learning, and in the second half of the year they might have their clinical learning. So just depending on where the COVID spikes were happening would impact how much their clinical learning was going to be affected. For example, I think it was in 2021, the first spike was at the beginning of the year, but they were doing theoretical learning, so that was very amenable to online sort of remote learning. But as they finished that and were moving towards clinical education or the clinical curriculum, there was a second spike, and so they were quite at a loss at how to manage this clinical curriculum via online remote means. Given that there was a general, the gold standard, or the understanding was that the gold standard for clinical education was face-to-face patient interaction being in the space, there was a sort of a focus on kind of cramming the clinical content or curriculum into available timeframes when COVID restrictions had been lifted, and students and educators could go back to the clinical space. Educators felt a little bit stressed about this because not only do they have a high amount of students that they need to pass through and get them exposed to the adequate amount of clinical content, but also they were aware that the clinical breadth was reduced in this setting as well. During COVID and lockdown restrictions, there were employment of some novel strategies, including simulation as well as virtual virtual consults with patients via online platforms. And another strategy that was used was giving vaccinated students the option of staying on the clinical floor so that they could minimise the impact of not being on the clinical space and having that clinical interaction and authentic learning experiences. Right, but for the current batch of interns, if some says there's no spleen, no liver, you don't trust. You know, it's quite possible that they missed it completely because the only exposure they've had is anywhere between 2 to 4 weeks over a whole year. So this is speaking to trusting the new workforce, and it was identified as a major concern for a lot of educators as the new workforce were transitioning from undergraduate, from being students to young workforce. From the transition between 2020 to 2021, most of the LMICs were able to transition and make their transitions happen, so whether or not that was from undergraduate to postgraduate or postgraduate to subspecialties. Although they were acutely aware that this generation of COVID generation of young workforce may have reduced clinical skills, and so had to make some arrangements to compensate for that. And that really was in the form of increased supervision. In places such as the Solomon Islands and Fiji, they did have 2-year internship programs, and so that was seen as enough to suffice for making up for any lost time in terms of learning about the work and the clinical sort of practice. The next theme, and the last thing we're going to talk about, is evolving education online. And as I've mentioned, this has been split into 4. I'll just say overall LMICs were able to make a transition to some sort of online learning, and were able to continue education one way or another through this medium. So we don't get any training in how to use these tools, the IT and the tools that can help us teach. This is something that I had to learn on my own to figure out how to do it. So I guess that's the other barrier, not having the support to help with the students' virtual learning. So the general feel from educators regarding remote learning was that the introduction of it and the transition to that was very quick. And they felt that there was a lack of support and expertise to help them to do this appropriately and with good quality. This related to not only the use of technologies, use of programs, but also teaching pedagogies in regards to how to do this effectively. A lot of places didn't have any experience with online learning, and there was also, it appeared to be a lack of people with expertise with online learning formats that they could ask for some assistance and help with. A lot of educators describe a trial and error sort of approach to finding out what works, while this is limited by the fact that they didn't get much feedback from their students as well. One of the places where things have been affected, especially for a country which is low socioeconomic, one of the lower middle income countries, has always been internet access. And so this was also a very big sub-theme with remote learning. Essentially, it is centered around internet and technology. That's to say that without internet and technology, you can't do remote learning, but if these things aren't done well, then it really also hampers the quality of education that's being delivered. So with regards to internet, there was, across the LMICs, there was variable sort of access, but essentially a common theme was that if it was bad, it always hampered education and delivery of education via online formats, which makes sense. There's a lot of discrepancy in terms of the quality of the internet that people were getting between metropolitan centres and rural centres, which is also something we're fairly familiar with as well. There was also other things like costs associated with data, particularly with students who don't have any income, and some universities recognise this and were able to provide students with data so that they could access internet. And with regards to access, again, this was also identified by some universities, and they were able to provide their students with access, being proactive and providing them with access so that they could attend their lectures. With regards to technology, the possession of the right technology, including laptops and computers, was also relatively variable, some having them and some not having them at home. But overall, there was a general consensus that most students had access to mobile phones, although again, the teaching on this was a little bit variable, dependent on the internet, but also learning from small screens. If a slide had a lot of text, it was difficult to actually read that. So again, the quality of that education is also up for question. And then another thing about the technology is also usage, and this was probably more at the beginning of the implementation of remote online learning formats, and this is really to do with audio as well as screens. Sometimes people will have problem shooting that at the expense of cancelling a lecture and particularly that particular lecture not being rescheduled again. But I definitely got negative people. They keep on quoting me, Osler, you can't learn medicine without books, but neither can you learn just from the books. You need to have some patient contact. They're really against this online stuff. So we're talking about the drawbacks with regards to online learning, and there was definitely sort of a preference towards face-to-face learning as opposed to online formats. And this was kind of embedded in the fact that with online learning formats, educators felt like it was very difficult to engage students via screens. Educators found it hard to assess student participation, and they also found it a bit hard to control virtual classrooms, particularly when students had their screens closed. Another point that was raised was concentration. So having 6 hours of lectures a day, staring at a screen for 6 hours is quite difficult. And again, one of the major drawbacks, which I've alluded to before, has been the ability to conduct clinical curriculum. And as such, educators really did struggle with the ability to assess skills and competencies via online formats. And now in this situation, technology has become something that's sort of changed in our practice and still plays a vital role in the medical education in our country. We are now able to reach people we've never reached before, we could not reach before, and that's a good thing. So this is speaking to the affordances that remote education has been able to give a lot of places, and I'm mostly talking about two main things, really flexibility as well as access. So with regards to flexibility, it really is economy of time and place. So for educators, it's about being able to deliver education sessions wherever they want, at home, in the car, travelling to work, and then being very flexible with their schedules. Online formats also gave educators the ability to record, and so they were able to make banks of resources that students could access within their own time. And then one educator also commented that she felt like it improved the quality of the education they were able to deliver because she was able to review what she recorded and then make any changes so that she could kind of improve the quality of what she was delivering to her students as well. With regards to access, there are sort of two main components to this, geographical as well as access to expertise. So from a geographical perspective, as alluded to by that quote, through investments in new infrastructure that allowed for remote learning, they were able to access spread curriculum to places that they weren't able to reach before. And then with regards to expertise, so really this emphasis on the online environment, there was a sort of an emphasis on collaboration in that space, and so educators found that they were able to invite expertise from across the country or internationally to help teach their students. They were able to invite expertise specialists to help out with their assessments and increasing the validity of their examinations. There was one comment by one educator who said that their postgraduate, their junior doctors actually preferred online education because it actually gave them increased access to their consultants who they would otherwise only briefly see on a ward round. So actually sitting down in an online space, having that time with their consultants meant that they could ask more questions, get more out of their learning. So I guess where to from here in this setting? So in places where COVID effects may still be significant and where educators may still be struggling, how can we improve that situation how can we improve the education situation in those settings? How do we kind of sustain or consolidate those positives while also acknowledging the fact that there are potential catch-up and deficits that LMIC educators are having to deal with due to the effects of COVID? So I guess one of the main things from this study that really wanted to impress on was that remote learning appears to be one of those sorts of actionable things that we can help out with. as it provides a way of maintaining a standard of education, particularly through times of crisis, but also has the potential to increase the quality of medical education via connection and access. I think then we think that there needs to be a little bit, a focus before the online teaching momentum kind of peters away when COVID gets a little bit better, to help support and consolidate investments into remote learning infrastructure and practices, with a focus on capacity building on the ground. So how do we go about doing this? Before I go there, and I think this is a really nice quote from one of the educators from now. I think that the curriculum should be developed to be suitable for the world now today. As I said before COVID we didn't use online teaching. But nowadays we have to include online teaching in our curriculum. We have to learn from our peers, our neighbours, any way that we can to develop teaching. And so how do we go about doing this? And so I've taken a page out of Dr. Isaac Olufa-Dewa, who I believe is a fairly prominent advocate in the global health space for LMICs. He had a comment in the Lancet of Global Health in July, I think, last year, and proposed a framework of action that is designed to promote health equity by, and I'm just going to quote from what he said, introspective and forward-looking approach to propose actionable solutions to global health inequalities in low to middle income countries, while building relationships between high income countries and LMICs. And essentially there are three main components to this: bridging the capacity divide between professionals in HICs and LMICs, fostering a culture of collaboration between LMICs, and then funding and sustainability. So I'm going to sort of use this framework and just in the setting of perhaps trying to promote and consolidate progress made in the remote learning area, make some suggestions as what we could be focusing on. So with regards to bridging the capacity divide between professionals in HICs and LMICs, it really is about bringing expertise with regards to how to use technology and how to go about educating through online formats. So this could be introducing expertise in how to use technology effectively, introducing expertise on remote learning pedagogies and using an evidence base for that. And I guess one way that we can start doing this is by initiating these sorts of collaborations through existing relationships that we have at the moment. Of course, giving them the knowledge of how to do this wouldn't be very helpful if they couldn't do it. And so things to think about would be also to be help funding in infrastructure to help support that, whether that be technology or supporting like data, internet, and that sort of thing. The culture of collaboration between LMICs. So unfortunately, recently there's not really been that much collaborations between LMICs, and I think that's a little bit unfortunate because they all have shared stories, and each LMICs have been able to have their own successes, and in those settings, there are lessons that can be learned from one LMIC compared to the others. For example, there are definitely places that have a bit more successes with education delivery and assessment, places that have a bit more IT expertise, internet and access, and these are sort of points that could be shared between their peer LMIC colleagues to help them with their particular situation. So I guess how do we do this? This is a difficult question, and I would be interested to hear if anyone else had sort of any comments on how this might be best done. But I guess what we're really wanting to do as a first point is provide opportunities to develop relationships between LMICs. And I'm just going to do a bit of a shout out to the Paediatric Academy, which has just been essentially promoted, but just a forum where clinicians and educators can come together to collaborate, share ideas, and potentially form relationships where they might be able to help each other out. And then lastly, funding and sustainability. I'm not going to talk too much about this because I'm not particularly an expert in this area, but I would just say that in terms of funding, the role of government, and we're talking about foreign aid and what we can do as an HIC, and where do we direct that funding. In terms of sustainability, just developing policies and programs that have quality assurance embedded in them so that they don't peter away and that they can work on a cycle of continual improvement and review. So now I might invite Pauline into the conversation and to get a little bit of a Papua New Guinea sort of perspective on what's been happening down there. Pauline, are you... So Pauline.
Pauline, we just want to be able to see you in the room.
Yes. Yeah.
So thanks again so much for coming. I think we'll be really interested in hearing what your sort of experiences have been. But I guess I really wanted to just touch on sort of the main changes that were necessitated by COVID in terms of delivering education, particularly in the setting of restrictions. And particularly interested in hearing what investments had to be made in technology from your faculty to help facilitate remote learning.
Okay, thank you. First of all, we never had plans to move into virtual education, and until the COVID happened. And the reason why we never had plan is that it was never supported by our administrators of the university and other hospital institutions. So that's why it never occurred. So the COVID sort of pushed us. It forced the administrators, it forced the universities to invest in technology that could facilitate this virtual learning via the virtual platforms, especially by Zoom. So that was one of the good things that happened. The other thing is that in Papua New Guinea, we have a lot of trainees scattered around the country in the most remotest part of PNG, as well as within Moresby. And what usually happened before COVID was that we were not able to teach what we taught those, teach the trainees that what we were teaching the trainees in Port Moresby was not the same, was not being taught to those who were outside of Port Moresby. So they didn't have access to those teachings and tutorials. So this virtual learning, this COVID, what it did was open that door and allow us to be able to deliver the same tutorials to all our trainees within the country, so that there was uniformity in terms of medical education amongst all trainees within the country. Not just within the country, we had trainees as well who were enrolled from Solomon Islands, and they were able to join us virtually and be on the same platform as us and learn the same things we were teaching our trainees within Papua New Guinea. The other things that changes that sort of COVID necessitated was we usually at the end of the year have a final exam for all our postgraduate trainees, to which we only allow for one or two, at most two external examiners from Australia or New Zealand to come up and do the examination. But since the COVID, we've had more than two, and they were able to join us virtually. And that actually made it a lot more easier for us to make a proper assessment on our candidates, especially when we're doing viva exams as well as clinical short case exams. And medical education, which we usually have, as well as we have a weekly grand round that the major hospital in PNG, as well as the medical school, run for all medical professionals, inclusive of surgery, internal medicine, child health, and anesthesia, rural health. Everyone was able to come into that one platform. And we used to have it only within Port Moresby, but since the COVID, we've now reached out to the rest of the country, as well as the Pacific. We've had health professionals join us from Federated State of Micronesia, Vanuatu, Solomon Islands, East Timor, as well have been joining us for this continuing medical education program that we run for all health professionals in the country. So this was, I guess all of those events had to occur as a result of our administrators, university and hospitals seeing the need to invest in technology that could facilitate all that learning. So that was a good change, you could say.
I'd just like to ask, do you think that now that these changes have been made, that this is something that will be continued on into the future?
Yes, so we are now sort of moved, we still have COVID, but we have now sort of gone in hybrid, more into a hybrid type of medical education where we do some of it virtually when those teachings that need to get to our trainees in other parts of the country as well as overseas. We do that virtually, as well as clinicals as well. And we are also doing the face-to-face. There are some situations where we're doing face-to-face. What I forgot to mention, and I apologize, Eugene, was that one of the things we did not do, we hardly did, was simulations. And because none of us were trained in simulations, running simulations here in PNG. And what COVID did was sort of forced us to go into reading how to conduct it and learn it. And so that we were able to do simulations. For instance, in anesthesia, our medical students were able to go down to the hospital, but they were not allowed to intubate patients who had COVID. And so what we did was we had to acquire mannequins and run this as a separate class in a tutorial room, not a proper simulation lab, but just a tutorial room with one table and a mannequin, and get all our students trying to intubate this mannequin. So that was how we evolved our teaching. And we still do that now as sort of a startup before we allow our students to go down to the hospital and touch the real patients, which we did not do before. So that's what I mean by we're doing a hybrid now, sort of kind of teaching.
Great. I'm just cognizant of time. I did just want to ask you, so I remember you mentioning that Ranscott was able to help you guys out with some weekly teaching. I wanted to ask you that, like, how did that help out? How did that get established?
So because we had limited number of medical educators here in PNG, and now that we were dividing our classes into two in order to fit all the students into one room with, big space, was that we had to do a lot more classes than before. And so it got tiring, exhausting. So we had to get help from our colleagues in ANZCA, the Australian New Zealand College of Anesthesia, and the Australian and New Zealand College of Intensive Care, who stepped in and assisted us with teaching. So we still do that now. We're still running that. We do that twice every month, where there's teaching for all our trainees in PNG, as well as the Pacific Islands, from these two organizations. But COVID initiated that relationship and started off that mode of teaching.
I might open up to any other questions from anyone who's got questions.
Thank you very much, Pauline, Eugene and Amy. So for the virtual audience, please put your questions into the chat or the Q&A box. Pardon me. Very embarrassing to have a post-viral cough in these times. So I might kick things off in terms of questions, if that's okay. And my question is around access, because as Eugene and Pauline have both spoken to, I think one of the silver linings of all of this is the ability to access additional resources for people who are living in remote areas and even in different countries. Pauline, you mentioned some collaborations or relationships with other countries for CME and medical education, such as the Solomons and Timor. Can you please expand a little bit on, firstly, how those relationships were established, and then secondly, if you could give an example of some of the benefits that have come out of that?
So the relationships with the trainees in Solomon Islands and other parts of the Pacific is that they were enrolled. They originally enrolled to do postgraduate training with the School of Medicine, Health Science within PNG, but they were doing it under supervision of their local supervisors back in their countries. And that was how it was, and we get to see them a few months before the exams when they come into Port Moresby in preparation for the exams. What we had, because the other thing was that within PNG, we had our trainees were not only taking care of cases within the operating theater or intensive care, but were asked to take care of trainees asked to take care of patients who had COVID and assist ventilate them. So everyone was caught up doing all of that activity, trying to provide a service that we noted that especially our postgraduates, they were not getting enough tutorials as they were originally having. And so I then contacted ANSCA and then had a conversation with them and said, I'm worried that because everyone's so busy trying to provide that service for COVID patients, we need help to people who can continue these tutorials with our trainees. So, and that's when we planned that we should have it twice every month, and we should have it on a weekend so that there are people, those who are not on call, can attend that tutorial and at a time that we agreed. And how has that helped? Many of our trainees still find they actually like that session because they are able to get tutorials that they would not have from experts overseas that they would not have had if we did not have any virtual teaching. So we've covered topics on like child trauma or COVID in pediatric population and from different experts. So it's really opened that opportunity for better teachers to come in and step in.
Thank you very much, Pauline. Before I have more questions, but I just might ask the audience here live if they've got any questions for the panel.
I was curious, Lee Chin here, I was curious about, because you're crossing countries and your context of your teacher from Australia, New Zealand are in a different context to PNG. So how did that work out in terms of your tutorial content?
Pauline, did you hear that question?
Yes, I did. So yes, it was a worry getting theoretical teaching from our overseas colleagues. So what happened was the consultants, I would actually be attending those sessions as well. And I get to hear what the others have said with the trainees. And during the week, I then get to highlight those points that were taught during the virtually or weekend. So things that we learn on child trauma, and we have children that come in with trauma, then I get to teach that now based on so that there is a application of that theory into the practical means, clinical aspect. Yeah. So that's how we merged, sort of, it blended in all together. We had to make it work. And it required just us putting extra time to be there on the weekend, attending those classes with trainees.
Thank you, Pauline. I had another question for Eugene and Amy as well. With the research that you did, Eugene, you mentioned that simulation was one of the tools that was used a lot when countries were adapting to teaching in COVID. Did you find that simulation was used in a different way or a new way, or just more simulation?
I think the impression that I got with my discussions with the educators was that simulation really wasn't something that they were using quite very often, and so this was something that was necessitated from the COVID sort of environment. So I don't necessarily know if they were using it in a different way. I don't also necessarily know if they were using it in a way that we would use it here, so like that evidence base. So I think it's also an area that potentially, in terms of expertise, is something that we can also help them with as well. Yeah.
Thank you.
And I would actually just put that question to Pauline. I'm going to step in here, Pauline, and ask you that question. So from before COVID, you had no online teaching. You've mentioned you've started to look at simulation. If you had your wish list of what you'd like support with now, what would it be?
Oh yes, definitely intubating mannequins, pediatric mannequins. I don't have pediatric mannequins. I've got the neonatalis, the babies, the neonates. I have that, but I don't have pediatric mannequins. I had one intubating mannequin that got overused during the COVID, to the point where its jaw dislocated. So it had dislocated jaw.
The mannequins do suffer.
Yes, so I need those things now. Yeah.
And in terms of capacity for yourself or your staff or your educators, are there things that you particularly see as gaps or needs?
Sorry, I missed the last part of your question.
In terms of capacity or training skills for your educators or your university, do you see gaps or needs?
Definitely. I need. I've got now new academics and academics who've joined us who I would like to send overseas to have some training on how to do a simulation. So yes, definitely, if there's an opportunity for that, that would be really great. I forgot to mention the University of Adelaide Simulation Center tried to assist us. So what we did at one time was because we didn't have any mannequins and equipment, we did it virtually. They did a simulation in the center and then, broadcast it virtually. And my medical students sat in a class and watched everything. And at the end of it, they were like, we should do this a lot more. They were excited about, how intubation is done and it's seen, but done in a proper simulation lab. Yeah, thank you.
Thank you, Colleen.
And because of this, our medical school actually is now, within its 2 years, has built into its infrastructure to build up the first clinical simulation lab for our country because of this COVID that has pushed us towards that direction. So we really need all that help to do that setup for the lab.
That's fantastic. Thank you so much. Look, I think we're now just about reaching time, so I might, I'll just check the Q&A. I think there's one question there, which we might make the last one. It's Maz saying, thank you for your presentation. So 2 questions. The first regarding the Paediatric Academy, Eugene mentioned, is the aim that there will be members and contributions from low and middle income countries? And again, will this cross contexts?
I can speak to, hi Maz, lovely to hear from you online. The aim of the Paediatric Academy is that it will be a community of practice. And although we're starting with membership here on the Melbourne Children's Campus, particularly for global health, I'm very keen to grow a global health community where people can connect with that community, within that community with whoever they need to. So across countries and share experiences and needs.
Thank you, Amy. And finally, last question for Pauline. Did you use a specific online program for the simulation or just do it on Zoom?
We did it on Zoom.
Great. That was a perfectly short and succinct answer with the last minute remaining. So I'm going to take the opportunity on behalf of everyone here in the room and online and Melbourne Children's Global Health to thank Pauline, Eugene and Amy. Thank you all very much for your time and expertise and goodbye to all of you.